Ma'am, you can start. We are in live now. Thank you.
Yes. A very good morning to all the delegates. Myself, Dr. Lavanya Vaidikar, Associate Professor and HOD, Department of Pharmacology, Seven Hills College of Pharmacy. And let me thank all the participants for their active registration towards the webinar on methods of diminution of polypharmacy among geriatric patients, which is organized by IQAC Department of Pharmacology, Seven Hills College of Pharmacy, Tirupati. And I would like to welcome all the delegates for the webinar. And I request our beloved principal, Dr. M. Niranjan Babu Garu, to address the gathering.
Om Namo Venkateshaya. Namaste. Good morning. Hello everyone. Welcome to today's session. I feel honored to welcome the speaker of the day, Dr. E. Maheswari, Professor and Head Department of Pharmacy Practice, Faculty of Pharmacy, MS Ramaiah, University, Bangalore. All the principals, teachers, my fellow colleagues, my dear students, taking part in this webinar on methods of diminution of polypharmacy among geriatric patients. You can also follow us on YouTube, and in the end of the webinar, you can post your doubts. Great. Thank you, everyone. We appreciate you being here. Thank you very much. Jai Hind.
Thank you so much, sir, for your welcome note. Sunil? Yes, I take this opportunity to introduce about our college and our today's speaker, Dr. E. Maheswari Madam. Our college, that is Seven Hills College of Pharmacy, was established in the year 2007 with the dream of Dr. Venkatrama Raju Garu and visionary of the college, Dr. M. Niranjan Babu Garu and Dr. M. Sumulata Madam. So for their enormous dream of the educationalist and the striving nature towards the education made this college in the year 2007. It is exclusively established for the pharmacy education, which was established by Global Vision Educational and Welfare Society, which is a non-profit organization. And it is offering courses like PharmD, which is a 6 years course, and PharmD post-baccalaureate, which is a 3-year course, and B Pharmacy, which is a 4-year course, M Pharmacy, which is a 2-year course. And recently, we are very proud to announce that our college was recognized as a research center by JNTU Anantapur. And the college is approved by ACTE, JNTU Anantapur, and Pharmacy Council of India. And the college is accredited with NAC A grade, NBA, and recently we got approved by UGC autonomous status for a period of 10 years. This is the recent crown to the Seven Hills College of Pharmacy. And the college has, every year the college is placed with the students at different companies, like we have tied up with the different companies which was associated with the college for the past 10 years. And we have so many crowns to the institute that we ranked 50 in Swachhata rankings because of the greenery and the cleanliness, which was the care taken by our renowned visionaries of the college. So that is the replication of the ranking 50th in Swachhata rankings. And recently we got Green Mentor Award for adapting to 3 villages nearby our college, and we have achieved 100% ODF with our active participation of the students. And as a indication of the ODF achievement, we got Green Mentor Award from the MHRD. And additional societal services which was taken by our institution towards the society is drug information services, through which we can serve or we are serving to the society in a very close manner. And this is additional crown to the college, that is GIFS, Journal of International Pharmaceutical Sciences, where publishing the research papers all over the country. And there are so many societal activities which was doing by Seven Hills College of Pharmacy, and which was published in the newsletter which is owned by the Seven Hills College of Pharmacy, and it is publishing every 3 months regarding the societal activities what we are carrying out, and the drug related information which was carried out by our students and was published in the newsletter which is available in our college website. And our principal, he is very close to the societal related problems, and he used to do so many societal activities like blood donation camps, awareness camps, and whatever the anti-corruption challenges and anti-corruption bureau activities, so that directly or indirectly helping the society in facing the challenges of the problems, or any awareness regarding the diseases or the problems which are associated with the society. So with this brief introduction, I'm very proudly can say that I am being a part of the Seven Hills College of Pharmacy. Thank you. And let me introduce today's expert, Dr. E. Maheswari Madam, my guide, philosopher, and I can say she is a mother to me also. And I have been associated with her from my B.Pharm onwards. I am very much honored to read the biodata of my mother. So she is the professor currently doing as a professor and HOD, Department of Pharmacy Practice, MS Ramaiah Institutes, Bangalore. She did her PhD from Sri Padmavati Mahila University in 2013 and M.Pharmacy from MGR Medical University. And recently, Madam received Outstanding Professor of MS Ramaiah Institutes for her recognition of contributions and efforts made at the Department of Pharmacy Practice. And she is the member of many professional bodies, and she is the recipient of many international travel grants for presenting her research contributions in various international and national seminars and conferences. And she guided more than 50 projects for PharmD, B.Pharm, and M.Pharm. And she is currently doing so many other academic activities. So with this short note, I would like to introduce the expert tab to the audience. So she is now presenting the webinar on methods of diminution of polypharmacy among geriatric patients. Over to you, madam. Thank you for giving me such an opportunity to introduce you for our audience. Thank you, ma'am.
My sincere thanks to both of you, the principal, Seven Hills College of Pharmacy, as well as my beloved student, Dr. Lavanya. So thank you very much for a very good introduction. And it is good to hear about Seven Hills College of Pharmacy. You're doing so many societal services, adapted 3 villages, doing a wonderful job. Thank you for the opportunity provided, and also to my thanks to Sunil Kumar for his coordination. Thank you. Now we can start with the webinar. Thank you, sir. Is it visible, Lavanya? Slides are visible?
Yes, madam. You
Slides
can
are
go
visible.
ahead with the Sure, madam.
Yeah. It's my pleasure to meet you all through methods of diminution of polypharmacy among geriatric patients. So, Lavanya has given a good introduction. I'm Dr. E. Maheswari, Professor and HOD, Department of Pharmacy Practice, Faculty of Pharmacy, Ramaiah University of Applied Sciences. So, the topic for today's webinar is
Excuse me,
methods
ma'am.
of.
Sorry to interrupt. I think you have Zoom outage, ma'am. Zoom in it was there. It's not fit to the screen. Just check it once, ma'am.
Doing a wonderful job. Is it okay now?
Just
Okay
try
now?
to present it, ma'am, in a present mode. Yes, ma'am.
Yeah, fine.
Just go to presenting mode, ma'am.
Yeah,
Yes,
it's
ma'am.
been
Fine.
presenting.
Perfect. Thank you so much, ma'am. You can continue. Thank you.
Sure. Thank you. Thank you, Sunil. So to start with, so today's topic for the webinar is methods of diminution of polypharmacy among geriatric patients. So why is it important to know about it? So in this webinar, we will discuss what is polypharmacy. And as per WHO, World Health Organization guidelines, geriatric patients refers to patients those who are aged above 65 years. But in Indian scenario, if we look at based on the retirement age fixed by the government, we used to consider patients those who are aged above 60 years as geriatric patients. So in this webinar, what we are going to learn is about the methods by which you will be able to minimize the polypharmacy among the geriatric patients. So what is polypharmacy? So polypharmacy, when you look at it, is the use of multiple medicines. Commonly referred to as polypharmacy is common in the older population with multimorbidity, as one or more medicines may be used to treat each condition. So as the term itself indicates, it's a polypharmacy. So pharmacy, the medications it refers to, and poly, the multiple medicines. So which number can be designated to this polypharmacy? For example, if it is more than one, it is multiple medicines. So if it is more than two, it is generally referred as polypharmacy. And like this, based on the research articles, people got different opinion to term polypharmacy, whether it is more than two medicines or 10 medicines or 20 medicines or what is it. So a systematic analysis, systematic review was done to determine what is polypharmacy, what is minor polypharmacy, what is major polypharmacy, hyperpolypharmacy, and excessive. So in case of minor polypharmacy, it refers to consumption of 2 to 4 medicines per day. Major polypharmacy, more than or equal to 5 medicines. Hyperpolypharmacy, more than or equal to 10. And excessive polypharmacy, more than or equal to 21, which was recently introduced. So why this has come? Why we have to discuss about polypharmacy? Because in the current scenario, when you look at, there are multimorbidities. When you look at the patients, mainly the pharmacy practice as well as the PharmD student, those are visiting the hospitals, you'll be knowing if you want to collect a case for your case presentation, any single disease, will you be able to get very rarely. So most of the patients, they are having comorbid disease conditions, which leads to multimorbidity. And even when one particular disease, when the person is suffering with, the person used to receive 2 to 3 medications. And when it is multimorbid in nature, multiple medicines are received by the patients. With our regular practice itself, day-to-day life practice itself, we have observed that for simple medicines, whatever we are taking, like paracetamol, if we take, it will lead to gastric irritations. And similarly, diclofenac, if you take, gastrointestinal disturbances are very common. Like this, for the simple medicines, when there is multiple side effects, for the drugs which are going to come under the category of polypharmacy, there are multiple medicines consumed by the person and which leads to various side effects also. So it is very much important to minimize this polypharmacy, otherwise the persons will get side effects. because no single drug is free from side effects. So when 10 medicines and more than or equal to 21 medicines in case of excessive polypharmacy, when he is consuming, patient is consuming, along with his own illness, for the illness he has taken medicines, and for the treatment of illness, again he is dumped with, overloaded with multiple medications. So it is very much important to know what is the methodology by which we can minimize this adverse event, adverse conditions. So this includes over-the-counter. So polypharmacy, when we say, we shouldn't think that whatever drugs that is prescribed by the physician, that alone is considered as polypharmacy. No, that is not. So this includes over-the-counter medicines. Other than the medicines, whatever has been suggested by the physician, the patient also used to take some medicines on his own. Maybe for some regular body pain, arthritis, knee pain. All these things are very common in case of elderly. And on their own, they used to consume the over-the-counter medications, mainly the NSAIDs. And also nowadays, it's very much fashionable medical field, pharmacy field. When you look at it, is traditional consumption of traditional and complementary medicines. So multiple medications the persons are consuming on their own, or it might have been suggested by some other patient who is suffering with other comorbid diseases. If it is in case of diabetes, it is very much common to consume the jamun seeds, isn't it? The powder of it they used to consume, or else to improve the overall health of the individuals, they used to go for consuming the aloe vera juice. Like this, depending on the region, one particular medicines they used to have it in common, and they do not consider it as medicines or pills. So we should know what is appropriate polypharmacy and what is inappropriate polypharmacy. So what is this appropriate polypharmacy? Whether the medicines prescribed for the purpose of achieving specific therapeutic objectives should have an indication, isn't it? So if there is an indication, then the drug should be prescribed. And if not immediately, at least the therapeutic objectives should be met within the near future, should be achieved in the future. Or else the medication therapy has been optimized to minimize the risk of adverse drug reactions. And the patient is motivated and able to take all medicines as intended. For example, the fourth one, if you look at, the patient should be motivated, isn't it? Many people, they'll go for regular consultations, and after the consultations, they used to take the medicines. They used to take the medicines, buy the medicines, but later they will not take it regularly. It may lead to patient non-compliance or medication non-adherence also. So the patient is motivated and able to take all the medicines as intended. That is important. Means that the physician is supposed to discuss with the patient whether he is willing to take a medicine for this purpose or not. Inappropriate polypharmacy. So what is that? When one or more medicines are prescribed that are no longer needed, either because there is no evidence-based indication, the indication has expired, or the dose is unnecessarily high. So there should be an indication for which there should be a evidence-based prescription, and if the symptom subsides, he need not take. For example, if a person is suffering with fever or other common ailments, most of the patients, when they go for a consultations, they were not given a proper guidance stating that whenever there is elevated body temperature, consume this. So it will be made as TID, isn't it? So thrice a day, the person is supposed to take the medications. So sometimes what will happen, with one dose itself, the fever might have subsided. Unnecessarily, the patient might have taken 2 extra doses also. So if the indication has expired or the dose is unnecessarily high, one or more medicines fail to achieve the therapeutic objectives they are intended to achieve. Means inter-individual variation will be there. So sometimes even after taking the medicines may not be working for that particular individuals. It may be tolerance or based on the receptors or sensitivity of the individual. So one or the combination of several medicines cause ADAs or put the patient at a high risk of ADAs, or because the patient is not willing or able to take one or more medicines as intended. For example, if the medicine is intended for joint pain, he may say that I don't want to take a medicine for my joint pain. It is because few people, they will understand the nature, physiological nature, isn't it, changes. So they accept that So these type of mild pain, knee pain, all these joint pains are common, and they don't want to take a NSAIDs for those purposes. So you have to confirm it. And another thing is same class polypharmacy. What is that same class polypharmacy? Under the same category, sometimes two medicines will be there. Mainly in case for the people, those who collect the cases from the hospitals, they might have come across this particular issues, isn't it? So one for one particular indication and another for another these things. Multi-class polypharmacy, use of more than one medication from different classes for the same symptom. ACE inhibitors and calcium channel blockers. Adjunctive polypharmacy, use of one medication to treat the side effects of another medication from a different class. For example, if antibiotics are taken, what will happen with antibiotics to inside the gastrointestinal system? Within the intestinal regions, there are chances by which all these things will be destroyed. The commensals will be destroyed, isn't it? So once the commensals, the good bacteria which are helpful for the absorption of nutritional substances, if it is destroyed, what it will lead to? Whatever you consume again will not be absorbed properly. So always they used to supplement in case of antibiotic consumption, probiotics. And along with probiotics, if the patient is weak, there will be multivitamins also. That will lead to adjunctive polypharmacy, additional therapies. Augmentation polypharmacy. What is that? Use of one medication at a lower dose along with another medication from a different class in full therapeutic dose for the same symptom cluster. In those cases, that may lead to increased bioavailability. What are the factors that contribute to polypharmacy? One important factor is increasing age. So before, some 2 decades before, when you look at a person is suffering with or dying with cardiac diseases, it was rare incidents, isn't it? Sometimes, very rarely, we used to hear about it. Nowadays, a person who is getting a myocardial infarctions and mortality is also very common between the age group of 30 to 35. So in those cases, in the current scenario, think about the geriatric populations, 60 and more than 65 years of age, increasing age, senescence, isn't it? So as age progresses, most of the systems which is normally functioning before, the physiological abnormalities, changes will be there. As a result, that will lead to multiple symptoms, multiple medical problems or comorbidities. As a result, copious prescribing. Because what is happening now? Multiple medical problems. So we know that before, a few years before, 2 decades before, there will be general medicine physician only who is treating all the diseases. Nowadays, specialty clinics are available for treating each of the systems. So any problem with the diabetes, all these NCDs, we will go to the diabetologist. And when there is some kidney abnormalities, we will go to the nephrologist. And similarly, cardiac diseases, cardiologist, isn't it? And what is a mistake? It is right to approach all those specialty people. But what is a mistake that will happen there? We are not going to reveal the medicines what we have been prescribed by the diabetologist to the nephrologist and to the cardiologist. So in that case, there are more chances for drug duplication to occur. Okay, so what that will lead to? Again, unnecessarily, we are overloading our body, which will also lead to polypharmacy, medication non-adherence. The patient will get disturbed, depressed. So he will think that why should I take all these medicines, and they will stop taking medicines. And if the person is financially poor, again that will affect. He can't bear, he will not be able to afford to bear the cost of the medicines. So multiple providers, doctor shopping, isn't it? So once if you go to, we expect the disease to get cured immediately after taking the medicines. So what will happen? Immediately after consuming the medicines, the person will go and consume it for 1 week. If the symptoms are not changing immediately, he will think that he will express to someone, or he himself will not be satisfied, by which they will think that the medicines prescribed by this particular physician is not good, or my relative or friend or someone who suffered with the same condition, he got cured immediately. What he will do? He will get those details and forgive all these medicines, forget about it, and he will go for the next category of drugs. So polypharmacy may lead to increased length of stay in hospital and readmission to hospital soon after discharge. So that is also increasing the polypharmacy, as well as the person is also going to suffer with financial burden. Age-related changes. So because of geriatric conditions, as age progresses, it causes multiple changes, both pharmacokinetic changes as well as pharmacodynamic changes. Pharmacokinetic changes, when you look at it, includes the ADME, isn't it? Absorption changes, distribution, metabolism, excretion of the drug. And pharmacodynamic changes in receptor affinity, receptor number, downregulation or upregulation may happen. Changes in response based on the downregulation and upregulation of the receptors, and changes in homeostasis control, isn't it? So what is the problem here? Polypharmacy, how this will lead to polypharmacy when you look at the drugs, whatever is consumed by the geriatric people, clinical trials are not done for the geriatric age group, isn't it? Similar to that of a pediatrics. Pediatrics as well as geriatrics, their dosages are adjusted based on the adult dose. The adult dose, whatever is administered for the disease conditions, those doses, it is extrapolated in case of geriatrics, and based on the child dose calculations, it is reduced in case of the pediatric populations. So that is another disadvantage by which the geriatric populations are more susceptible to adverse drug events. So knowing about all these things, what we understand, the necessary drugs alone should be administered to the geriatric populations. So the common risks of polypharmacy, when you look at the most vulnerable patient groups to the risks of polypharmacy, are susceptible to events such as drug-drug interaction may happen, because when you solve for your case presentations, when you collect the cases and solve, if there is 5 drugs, because most of the hospitals, pharmacy institutions nowadays, they are using various softwares, Micromadex or Lexicomp, like that, right? So with that, when the students solve the cases, what they will come across, even if 5 drugs are present, within that, there are more chances of 3 drug-drug interactions also sometimes. So drug-drug interactions and drug-food interactions. Mostly ignored part is drug-food interactions, because many are not aware. The common drug-food interactions, when you look at in case of statins and all, statins, the drugs are the drugs which are utilized in case of hypercholesterol, isn't it? Hyperlipidemia. So in those cases, if you go for administration of food or fruits such as grapefruit juice, sakota they will be saying, isn't it? Similar to that of orange fruit. So that fruit, when you take, it is causing alterations, and the statins bioavailability and therapeutic activity is decreased. So drug-food interaction is common. Drug disease interactions. If there is renal impairment or else a hepatic impairment, and when the drug is taken at the same dose without considering the other impairments, what it will result in? More chances of accumulation of drug within the body, increased bioavailability, which will also cause toxic reactions in the body and adverse events. Herb-drug interactions, because of the consumption of complementary and alternative medicines. Higher risk of falls. So the higher risk of falls, when you look at, there are so many medications which are consumed by the geriatric peoples, which is also causing changes in the calcium level in the body, which will lead to hypocalcemia. Once it leads to hypocalcemia, it will lead to the conditions of osteoporosis. As a result of osteoporosis, he used to suffer with often frailty and fractures. ADRs, adverse drug reactions, are very common with the polypharmacy. Cognitive impairment. So as physiological process also few people will have, and with the drugs also there is drug-induced cognitive impairment is also common. And poor nutritional status. People, they minimize the self-care over consumption of food. All these things will be minimal, isn't it? Unless otherwise a caretaker is there to take care of them. So poor nutritional status, or because of financial problems also, this may lead to. So the vulnerable patient groups often include older patients above the age of 65 years and patients those who are living in care homes. That is, in case of old age home, those who are living, not much care will be, means regular care is not provided in all the old age homes. So management of polypharmacy. Globally, the prevalence of polypharmacy is set to rise. Because of the advancement in medical field, there are multiple techniques by which you are able to take care of the geriatric population's health. As a result, there are the age of the geriatric patients are long, isn't it? The lifetime is increased. So it is set to rise as the population ages and more people suffer from multiple long-term conditions. Countries should therefore prioritize raising awareness of the problems associated with inappropriate polypharmacy and address this. And all the stakeholders, who are all the physician, nurses, pharmacists, all the healthcare professionals should play a vital role to provide a driving change for the management of polypharmacy. It involves multifaceted decision making, which necessitates the combined knowledge of physicians, nurses, pharmacists, and other healthcare professionals, including the systematic involvement, engagement, and empowerment of patients also. So, to manage the polypharmacy, how we are going to do, what is possible? It is important to implement interventions such as medication reviews whenever possible in collaboration with the patient or the caregiver. So good communication and accurate sharing of information is essential and can be facilitated by the use of patient health medication records. So what is the solution for this? There are various guidelines which will help us to avoid the medications which are commonly causing the adverse events and adverse effects in those patients. So which are the tools? One is BEES criteria, which is revised recently. Start criteria, start-stop criteria. So what is the start criteria? Screening tool to alert to right treatment. Start criteria, screening tool of older persons' prescriptions. So these start-stop criteria, they give us a clue that what are the potentially inappropriate medications commonly used in older adults and that can be avoided, or which are the potentially inappropriate medications which will lead to drug disease or drug syndrome interactions. And another table is provided which will give a clue about the potentially inappropriate medications to be used with caution in older adults. So drug therapy review and de-prescribing plays a very important role in the management of polypharmacy. Key steps for ensuring medication safety. What can be done? Conduct a risk-benefit analysis. If the risk outweighs, in those cases, go for dosage reductions. If the benefit outcomes and if the risk is low, you can go ahead. So appropriate prescribing and risk assessment should be done. Medication review should be done. Dispensing, preparation, and administration. Communicate properly with the patient. Engage with the patient. Say, these are the medicines. This is the time of administrations. Mainly, after getting the medicines, sometimes the patients may not be knowing how to handle the situation itself, isn't it? So he was given a list of drugs, when to take, how to take. He needs some help. Mainly in case of people as age progresses, there will be changes in the eyesight and all, isn't it? So they should be cared properly. And there is a general concept that any medicines given for any purpose, when the persons, what is the mindset of the people? They will not question the pharmacist, isn't it? So what they will do, they will get the medicines and they think that have meals and after the meals, they will consume all the medications. But that is not the criteria, right? So few medicines should be taken early in the morning, few medicines half an hour or 1 hour before food, few medications 1 hour or half an hour after the food. It depends, isn't it? So all these informations are not reaching the people. So communication and patient engagement is important. Medication reconciliation and care transitions. Review of the patients at care homes, old age homes is also important, by which polypharmacy can be avoided. So de-prescribing. How de-prescribing is helpful in the process of diminution of polypharmacy. It is the process of tapering. Minimize the dose from 10 to 5 mg. Stop the dose if it is not required, or discontinue the medications or withdrawal of the drugs with the goal of managing polypharmacy and improving the therapeutic outcomes. It encompasses minimization of medication load in terms of dose, number of tablets taken, and frequency of administration times. Even the frequency, instead of taking TID, if it becomes OD, how good it will be, isn't it? So sometimes 4 times a day to 3 times a day, it may be required only for once a day or twice a day, isn't it? So the frequency of administration if it is minimized also, the unnecessary exposure of the drug in the body is minimized. So continuation shouldn't be seen as a passive or default actions. De-prescribing needs to be weighed equally against the decision to continue. Supporting tools such as Beers criteria, start-stop criteria are useful. And nowadays, there are so many de-prescribing algorithms. In this webinar, I will explain you about few of the de-prescribing algorithms, but there are multiple also for even with the other medications. So de-prescribing, you should handle it very careful because it is medicines and it is health of the patients. Already the patient is suffering, and to that patients, if you are without the consent of the physicians, if you minimize it, it is a faulty activity. So the general rule for de-prescribing is, and it should be done under the supervision of the treating physician and healthcare professionals. Consider the risk-benefit ratio. Do it in concern with the patient, caretakers, and family members. And perform it as a shared decision making. Involve the patients, involve the family members and caretakers, ask their opinion. Okay. Mainly, when you do the shared decision making, you have to explain about the different brands available, what is the cost of those brands, by which whatever is possible for financially possible for the patient, that can be chosen. The choice should be given to the patients. Explain the patient how the risk outweighs the benefits if continued, and adverse effects, financial burden, and pill burden. Monitor the patient after de-prescribing for relapse of symptoms, if any. And there is very important step. We want to, since the risk is more, if at all we suggest them to, if they taper the dose, we shouldn't leave it. Yeah, taper the dose, next time you come for a review. We have to advise them about the monitoring parameters. So monitor the patient after de-prescribing for relapse of symptoms, if any. If symptoms relapses, how to handle the situation meanwhile before consulting the physician, and should consult the immediately the physicians. So if they reoccur or worsening of symptoms occurs, consult the physician and restart the therapy. Prudent prescribing. There should be a far-sighted thought when you are considering a prescribing. So thoughtful prescribing about the future. What and all the common drugs. Nowadays, many people suffer with gastrointestinal ailments. So the proton pump inhibitors, and it is widely abused, isn't it? So many of you might have observed that any prescription you take, if one antibiotic is there, along with that one proton pump inhibitor will be there. And many people, those are having minor sleeplessness, insomnia, they are also considered as psychotic individuals, and they will start with the psychotic therapy. Benzodiazepines and Z-drugs, which are acting as sedatives and hypnotics. Bisphosphonates, mainly in case of elderly populations. What is the major complications? Hypocalcemia, isn't it? So to minimize the osteoclast activity, they are commonly prescribed with bisphosphonates, vitamin D, and calcium supplements. It should not be given individually, together to get a good effect. So first we will look at the de-prescribing of proton pump inhibitors. So why the drug should be de-prescribed? Proton pump inhibitors, if one drug is there, what harm it is going to cause? That is what we used to think before. But with the later research articles and the statistics, it shows us and gives a clue that the common drugs, omeprazole, lansoprazole, pantoprazole, rabiprazole, esomeprazole, and dexlansoprazole. So these common PPIs, they used to cause higher risk of fractures, Clostridium difficile infections and diarrhea, community-acquired pneumonia, as well as hypomagnesemia. These are very common, and the common side effects include headache, nausea, diarrhea, and rashes. So we never imagined that the PPI is going to cause a fracture, or it is going to cause some chronic kidney diseases, or it is going to cause hepatic damage, as well as dementia, as well as various other polyps and other polyps growth also. So de-prescribing of PPI, the PPI consumption should be minimized if it is consumed more than the specified duration. What is the durations? Commonly, if it is in case of peptic ulcer diseases, it is suggested to consume the drug only for 3 months duration. That is 12 weeks duration we are supposed to consume, not more than that. After the 12 weeks, the patient is supposed to come for a review. So only we should take more sincerely, we should go for a revisit, reconsultations. So after prescribing, the doctor might have suggested to the patient that after 3 months, consume these drugs for 3 months. After that, you come for a review. If you fail to go for a review, what it will result in? There are more chances of unnecessarily burdening your body with the PPIs also. So, and many people, they believe that because the irritation and the regurgitation, those who had the experience of peptic ulcer, only they can understand, gnawing type of pain. So what will happen? The patient feels that if I stop this PPI, because after taking the PPI, he might have felt a complete relief. And if he stops this drug, what may happen? Again, all these symptoms may relapse again. So he will continue with the PPA on his own without going for a review. And we have seen cases in our hospital settings where the patient has consumed the drugs even for 10 years, 20 years durations also. So it is important to go for a review and go for a de-prescribing process. In which conditions we can go for a continuity of PPI? If it is a Barrett's esophagus, where there will be ulcerations, and chronic NSAID users with a bleeding risk, severe esophagitis, documented history of bleeding gastrointestinal ulcers. So the patients or the caregivers may be more likely to engage if they understand the rationale for de-prescribing. So we should discuss with the patient and the caregiver, this much is the original duration actually required. Or else if they want a proof and if the patient is not worried about the past symptoms of peptic ulcerations, then you can suggest to the patient that we can go for endoscopy, and if the wound is completely healed, you need not continue with the drug. So when and all you can go for a de-prescribing of PPI. Peptic ulcer disease, and if the patient is treated for 12 weeks, do not require to continue more than 12 weeks. Most of the time it will be healed within that duration, unless otherwise it is a severe. So only you are supposed to go for a regular visit with the physicians to determine it. Upper gastrointestinal tract symptoms without endoscopy and asymptomatic for 3 consecutive days. So if the person didn't go for endoscopy, sometimes even people are worried about endoscopic procedures, about the tube insertion and all. So in those cases, if they, after stopping the drug for 3 continuous days, if there is no relapse of the symptoms, it indicates that the ulcer has healed. So can suggest de-prescribing. Or intensive care unit stress ulcer prophylaxis treated beyond ICU admission. When the patient is admitted for any ailment to the intensive care unit, first of all, when diagnosed with the disease, the patient will be stressed. And if he is taken to the ICU, definitely the patient will be stressed. And uncomplicated H. pylori treated for more than 2 weeks and asymptomatic. In all these cases, you can go for de-prescribing. Mild to moderate esophagitis or GERD, gastroesophageal reflux disorders, if it is treated for 4 to 8 weeks, most of the time it is under control. Symptoms will be under control. Esophagitis might have got healed. So decrease to lower dose, stop and use on demand. Whenever there is a irritation, that time we have to take. So monitor at 4 and 12 weeks, heartburn, regurgitation, dyspepsia, epigastric pain, loss of appetite, agitation, weight loss. These are common symptoms with PUD, right? If it happens, if it occurs, in those cases, initially suggest them try with the non-drug approaches. Why to dump the body with the medicines always? Try, take risk 1 or 2 days. So avoid meals 2 to 3 hours before bedtime. What are the non-drug approaches? You should not eat and immediately go to bed. So that itself will cause more of regurgitations, mainly in case of geriatric peoples. So avoid meals 2 to 3 hours before bedtime. Elevate the head of the bed so that regurgitations can be minimized. Address the patient if required for weight loss and avoid dietary triggers, because more obesity, there are more chances of hiatus hernia and more chances of regurgitations. And dietary triggers, if the person is having social habits as well as more consumption of more spicy food items, that will also cause dietary triggers. So that should be minimized. Manage occasional symptoms with over-the-counter antacids. H2 receptor antagonist, PPI, alginate, sodium alginate, chlorineta, whenever it is required. H2 receptor antagonist daily. So these are the things you can manage for the occasional symptoms. If symptoms relapse, if symptoms persist 3 to 7 days and interfere with the normal activity, test again for H. pylori infections and consider return to the previous dose. So inform the patients about good healthy lifestyle modifications that can prevent the medicine intake. Senior citizens are one of the more common group who fall victim to polypharmacy problems. There is often a lack of communication happening. The drug overuse can be very dangerous. The costs are skyrocketing. Imagine a PPI, since it was consumed for a longer duration, that has resulted in kidney damage. Means who will believe? It has resulted in a fracture by which the patient is suffering with means helpless activity, and the quality of life has affected. It is pathetic, right? So we have to take care of even the minor drugs what are commonly utilized as OTC drugs. It's possible to avoid overprescribing. PPIs are overprescribed with antibiotics generally. Antibiotics, when you take, how long you're going to take the antibiotics? Not lifelong, isn't it? It is not for NCDs. So in those cases, what can be done? Only maximum of 5 days, 3 days, or 7 days it will be consumed. So in those cases, within those 7 days, the person is not going to get a peptic ulceration, isn't it? So you need not go for a PPA always, but let it be there in the prescription and the patient be kept informed that if at all you get severe ulceration because of senescence, since it is in case of geriatric populations, SOS basis, as and when recurred, you are unable to bear the stomach pain or gastric irritation, consume it. That point should be underlined and stressed to them. So think about the change in pH and the pharmacokinetic changes. Whenever in all the prescriptions, if we go on, keep on adding the proton pump inhibitors, what it will do? It causes so much of changes, isn't it? So the drugs which will be getting absorbed only in the acidic medium will not get absorbed properly because of the change in the pH, isn't it? So change in pH, alkaline pH because of the PPA consumption. So decreased or increased absorption is possible. Another category of drugs where you have to consider is psychosis. So in case of geriatric people's, senile psychosis is also there, isn't it? As age progresses, few people they used to suffer with senile psychosis. So antipsychotic drugs should be administered. So continue the antipsychotic drugs if it is in case of schizophrenia, schizoaffective disorder, bipolar disorders, that is both anxiety and depressions, acute delirium, mental changes, Tourette syndrome and tic disorders, where the person intend to speak one word, something else will come out, isn't it? Autism kids, less than 3 months duration of psychosis and dementia, intellectual disability, developmental delay, obsessive compulsive disorder, isn't it? Alcoholism, obsessive compulsive disorder, again and again, repeatedly they will do the same activity. Alcoholism, cocaine abuse, Parkinson's disease, psychosis, adjunct for treatment of acute major depressive disorder. In those cases, you're not supposed to go for de-prescribing. You're supposed to continue with the antipsychotic drugs. So when is it possible to minimize this? Psychosis, aggression, agitation. So if it is because of behavioral and psychological symptoms of dementia, that is BPSD, and if it is treated more than 3 months, it is not required. And if the symptoms are controlled, you can stop the antipsychotics. And if there is no response to the therapy, again you can stop the drugs. Or if it is in case of insomnia, primary insomnia or secondary insomnia, where the comorbidities are managed already, you can taper the dose and stop the antipsychotics slowly in collaboration with the patient or caregiver, 25 to 50%, and reduction should be done every 1 to 2 weeks. Because to avoid the adverse drug withdrawal events, monitor the patients 1 to 2 weeks for duration of tapering, the expected benefits, adverse drug withdrawal events. Antipsychotic side effects, APs are associated with increased risk of metabolic disturbances, weight gain, dry mouth, dizziness, somnolence, drowsiness, injury or falls, hip fractures, extrapyramidal syndromes as symptoms, abnormal gait, urinary tract infections, cardiovascular events, and death. So the risk factors includes higher dose, older age, which will also, antipsychotics will also lead to Parkinsonism and Lewy body dementia. So for sleep management, it is very much important to say that not only in case of psychotic individuals, as common geriatric people also, we are supposed to inform them as primary care, go to bed whenever, only when the person is sleepy. Do not use a bed or bedroom for anything but sleep or intimacy. If you do not fall asleep within about 20 to 30 minutes at the beginning of the night or after an awakening, exit the bedroom. If you don't fall asleep within 20 to 30 minutes on returning to bed, repeat again the same third step. Use your alarm to awaken at the same time every morning. First of all, using alarm itself will cause a disturbance. Okay, so use an alarm which will help you to wake up without much tension. Okay, by hearing the sound, you shouldn't get tensed. So it should be mild, like someone how they help you to pat you to get up like. Do not nap. Avoid caffeine after noon. Avoid exercise, nicotine, alcohol, and big meals within 2 hours of bedtime. Institutional care. If it is in case of old age homes when the person is staying, pull up curtains during the day to obtain bright light exposure so that the circadian rhythm will be maintained, isn't it? Sleep and wake cycle will be maintained. Keep alarm noises to a minimum. Increase the daytime activity and discourage daytime sleeping. Reduce number of naps, not more than 30 minutes, and no naps after 2 p.m. Commonly, it happens, isn't it? When the normal individual itself, when we sleep for a long time during the, if we have a nap by afternoon, then it will be difficult to get sleep at the right time during night. So offer warm decaffeinated drink, warm milk at night because it will help you to get sleep. Restrict the food, caffeine, smoking before bedtime. Have the resident toilet before going to bed so that a continuous sleep will be there, or else the napkins can be encouraged. Encourage regular bedtime and rising times. Avoid waking at night to provide direct care. Offer back rub and gentle massage. So far, by behavioral and psychological symptoms of dementia management, you can suggest the patients to have a relaxed state, establish a social contact which will help them to minimize the anxiety, and sensory, music or aromatherapy, structured activities, and behavioral therapy. Address physical and other disease factors, example, pain, infection, constipation, depression. Consider the environment, light and noise. Review the medications that might be worsening the symptoms. So de-prescribing of, next is de-prescribing of benzodiazepines and Z-drugs. So this is mainly administered for the conditions of anxieties and it. So as hypnotics and sedatives, commonly the Z-drugs and benzodiazepines are administered. So other sleeping disorders for which it is commonly administered include restless leg syndrome, unmanaged anxiety, depression, physical or mental condition that is causing insomnia or aggravating insomnia, alcohol withdrawal. So in those cases, continue benzodiazepine receptor agonists, minimize the use of drugs that worsen insomnia. Caffeine, alcohol will disturb sleep. Treat the underlying conditions. If it is in case of secondary these things, then that can be treated. Consider consulting a psychiatrist or sleep specialist. So why is the patient taking a benzodiazepine receptor agonist? Mainly in case of anxiety, past psychiatrist consult, whether may have been started in hospital for sleep or for grief reactions. So in those cases, if it is not going to last for a longer durations, you can consider the durations. Benzodiazepines, if it is taken more than 4 weeks, can be de-prescribed before the patient gets the addiction towards a particular thing. So recommend de-prescribing. Monitor every 1 to 2 weeks for duration of tapering. Expected benefits. It improves alertness, cognition, daytime sedation, and reduces the falls. The withdrawal symptoms. It should also be tapered appropriately with the help of the physician in concern with the patients and caretakers. Withdrawal symptoms, sudden withdrawal symptoms may result in insomnia, anxiety, irritability, sweating, and gastrointestinal symptoms. So in those cases, behavioral management and CBT, what we suggested in case of same antipsychotics is applicable here also, because both the things in case of insomnia, how to deal with the conditions. De-prescribing of bisphosphonates. Bisphosphonates are effective in the prevention of secondary fractures, with one fracture avoided for every 40 to 90 patients treated for 1 to 3 years. So many patients who have had 5 years of continuous treatment with an oral bisphosphonate will have ongoing benefit for the further 5 years. Imagine how much benefit it is going to give for another 5 years. But we will not stop it after, since we have consumed the 5 years of continuous treatment, we will keep continuing it only. So in those cases, unnecessary dumping and polypharmacy will be increasing. So if the bone mineral density, if it is remains low, T-score if it is less than or equal to minus 2.5, or there are incidents of vertebral fractures, continue the treatment. If it is above 1 T-score, that gives a clue that the person's bone mineral density is normal. He may not go for consuming these drugs. So a plan for regular, example, biennial monitoring of bone mineral density may be of benefit to monitor for any decline. Hypercalcemia. If the patient is consuming, what are the adverse effects of vitamin D and calcium supplements? Supplements and vitamin tablets also may lead to hypervitaminosis, isn't it, and other complications. So it should be taken care and consume it only with the medical supervision. Hypercalcemia it may lead to, which in turn will lead to gastrointestinal adverse effects, renal calculi. As there is hypercalcemia, the calculus formations within the kidney will also lead to renal calculi or renal insufficiency. Severe vitamin D deficiency may contribute to osteomalacia, and calcium or vitamin D supplementation was a component of majority of studies of osteoporosis treatment regimens. So bisphosphonates, raloxifene, denosumab, all these things, what it will do, it will suppress the osteoclast activity by which the resorption of calcium from the bone can be minimized. If patients are receiving active osteoporosis treatment, then calcium and vitamin D supplementation is required. So, in which conditions we can go for de-prescribing? If there is lower risk of falls, or if the person has taken the vitamin D and calcium supplements for 5 years continuously, check his calcium levels. Once in a year, you can go for a serum calcium examination, lab analysis also. So that if the calcium and vitamin D is normal in the body, don't continue with the medicines. Otherwise, it will become as an extra pill burden and financial burden. So take care of this. And calcium, if there is regular milk supplementations, if the food supplementation through green leafy vegetables like methi leaves, all these things, if it is normal, all the dairy products, anyway, your body will receive it. And for vitamin D, exposure to sun within the duration of, means 11 a.m. to 12 noon, when you expose your body, there are more chances of vitamin D formation. So that will help the process. So instead of going for a calcium and vitamin D tab, let's do all these things. Statins, before you decide, discontinue if it is for primary prevention. If for secondary prevention, apply risk-benefit analysis with the consultation of the physician, and continue treatment only if it is for significant vascular risk like past MI or stroke. Harms, major uncommon or commonly elevated liver enzymes. Hepatic enzymes will be remaining elevated, which will also cause sometimes the minor symptom is myalgia, that is muscle pain will be there, and if it is not taken care, still the dose is not reduced, that will lead to the conditions of rhabdomyolysis, that is degeneration of the muscles. So risk of type 2 diabetes by 0.5% in predisposed, and decreased cardiovascular risk in many people. Memory loss and confusion is also possible with this as adverse events. Harms, minor side effects includes myalgia, muscle-related symptoms in 10 to 15% people. Residence cumulative causes aches and pains, and minor symptoms also includes nausea, gas, diarrhea, or constipation. What is the medications? So polypharmacy is also aggravated because of consumption of what is the medications. If the geriatrics are also, in case of pediatrics, few people, they have the habit of administering the cough syrup so that the child will sleep, no disturbance. The geriatrics, insomnia complications, they have to go for, first should try with the other relaxation techniques, what we discussed before. Instead, they used to go for cough syrup by which they will get a sleep. Anti-allergics, they are not for inducing sleep. Only in case of allergies, you are supposed to consume it. Counsel the patients before dispensing. Medication errors and ADS, if it occurs, support for a greater role of pharmacist in medication management and in collaboration with healthcare professionals for review of therapeutic plans. So opening of pharmacist consultation. So this should actually happen by which the polypharmacy problem can be minimized. Prescribing cascade. What is this prescribing cascade? Cascade is continuity. Prescribing cascade, continuously they will keep on prescribing. How this happens? When a geriatric patient suffering with arthritis, he will be prescribed with the non-steroidal anti-inflammatory drug, which will also, as adverse event, causes increased blood pressure. And for this, we will start treating what we have to do, we have to go for minimizing the dose, isn't it, of NSAIDs. And other occupational therapies you have to undertake. Instead, if you continue treating your hypertension, what will happen? So regularly, the drug consumption will be increased. Unnecessary overburdening, drug burden will be there. So arthritis, NSAIDs, adverse effect, increased BP, which will lead to increased blood pressure. Depression, tricyclic antidepressants we will take, which causes constipation. And for constipation treatment, again, we will go for a laxative. Instead, understand why this condition has occurred in this particular patient. Is it because of the drug already consumed by the patient or not? So that the prescribing cascade can be minimized. Agitation. If the person is having agitation, antipsychotic drugs are administered. Extrapyramidal symptoms, common side effects of antipsychotics, and as a result, that will lead to Parkinson's medicines consumption. Similarly, bisphosphonates, after 5+ years, if it is continued, more chances of hypercalcemia, which will cause renal calculi formations, and lithiasis, leading to chronic kidney diseases. Proton pump inhibitors and H2 receptor antagonists, they are a marker of hospitalization. So be careful with that. Years, 2 decades before, when a person is suffering with the peptic ulcer, what is the common thing everyone consume? Digene, right? So small digene will be available, and it is cheaper also, maybe 2 rupees, 1 strip, or like that only it was. So nowadays, it is more costly, isn't it? Proton pump inhibitors and H2 receptor antagonist, where it has gone, the sodium alginate as well as sucralfate and all those things. Whenever we ask the physicians about the prescription of costly drugs like esomeprazole and all, what they used to suggest us, say us, explain us, it is better efficacy. But is it really required for the patient or not? We have to think. Instead, go for the alternative therapies and the lifestyle modifications. First, suggest that if it is not under control, then go for these category of drugs. Otherwise, they are going to make the person hospitalized for fractures and liver damage and pulmonary problem, as well as chronic kidney diseases, which will also cause vitamin B12 absorption, as a result anemia. And iron tablets. More commonly, people think that old age means we have to supplement them with. Do they have iron deficiency anemia? Check it. If there is anemia, HB count is lesser, then you go for it. Antipsychotics. Whether it is really psychotic or not, psychosis or not, we have to determine. Because as age progresses, sometimes because of expectations, the behavioral change may be there. For all those things, you do not treat them with the drugs. Treat them mentally, emotionally, comfort them, by which it can be treated properly. So this is one of the studies which was done at Faculty of Pharmacy, Ramaiah University, by our students in the hospitals. So it is de-prescribing of benzodiazepines and Z-drugs amongst the psychiatric patients of a tertiary care hospital. It was published in Asian Journal of Psychiatry with a good impact factor around 2. So drug therapy review will help to minimize this problem of polypharmacy. So what should be done? Whenever the physician suggests the patients come for a review, go at time for a review. Don't think that it is a waste of money. Maybe the physician properly may taper the dose and give you a right amount of dose reductions. The pill burden will minimize. So annual wellness visit is important, which will help to have a health risk assessment, a wellness schedule, advanced directives, and a personal health record. Intensification or de-intensification of medicine is possible. The patient should go to the physician first, isn't it? We can't blame the physicians. So once he prescribed, later you are supposed to go for a review therapy so that he will go through the prescription and help to either, depending on your symptoms, if the seriousness of illness is more, then he will intensify the drug. If it is minimized, then de-intensify, mainly in case of diabetes, for insulin and all, you are supposed to go for a consultation. De-prescribing reduces the drug burden as well as the financial burden. So the drug therapy review should be done based on the brown bag method. if an untoward symptom is experienced by the patient who is taking the drugs, instead of going for a prescribing cascade, suspect the drugs present in the prescription and check for it. So these are some of the networks which will help you to do some research on de-prescribing. It is more common in Australia, Canada, and US, and it is also spreading to Tasmania and other places nowadays. So even in Indian scenario, it is an important. We need to help our as community helpers. We pharmacists are supposed to play important role and facilitate the process of de-prescribing and minimizing the polypharmacy. So make an attempt to do it. Undertake so many research projects based on this wherever possible, and you can help the geriatric populations and the society. So this is the final slide, which will give you the complete methods by which you will be able to reduce polypharmacy. Have patients bring brown bag method. That is, before and all, in our country and all, what we will do, yellow bag method, isn't it? So we used to have a small yellow bag in which most of the things we used to carry before. So the same thing you have to follow now. If you are going for consulting a physician, imagine that you will forget. You will have 1, 2, 3, 4, 5, 10, like so many things I have to express to a physician. After waiting in the queue for a long time, 600 rupees or something consultation, how much time you will get to interact with the physician? Maximum of 2 minutes most of the time on an average based on the research studies. So in the 2 minutes, you will forget to express whatever doubts you had, and all those things will not be clarified. So write in a paper and go and consult the physician. These are the things I have, and get the answers for it, either the method or time of administration, any other symptoms, whether it is because of side effects or not. Ask all these things, and then you will get a clear idea. And the physician will also be conscious to check whether it is a side effect of the drug or not. Okay, so brown bag method is very much important, and many people, if it is in case of doctor shopping or multiple consultation based on the specialty clinics visit and all, if you take it in a bag and show the physician these are the drugs, drug duplication can also be avoided. Also, the OTC drugs and herbal supplements, when you take, he will suggest you and say that this may cause drug-herb interactions, avoided, or take this only on these particular days or SOS basis. All those things will help to bring down the polypharmacy, hyper to minor polypharmacies. So always try to recognize all the medicines by their generic name and drug classifications. Even the medical council has forced people to make rules, guided the people to write only the generic names, but it's not in complete practice throughout. Always make sure that prescribed medicines possess a clinical indications, and always realize the side effects of the drugs to be prescribed. Have an understanding of how pharmacokinetics and dynamics of aging intensify the propensity for ADS. Do not use any medicine that doesn't have known benefits. Avoid the medicines without a clinical indications. Try to replace the drug with less toxic medicine, and be alert about the prescribing cascade. To the best possible, use the proverb, one disease, one drug, once a day. And most of the, almost in all the states, the PharmD colleges are there, and in each of the PharmD and the pharmacy practice institutions, they will have the softwares, and drug information centers are available. So the general public as well as the other persons, you just give a query to the students as well as the pharmacy practice department people or the pharmacology department. They will help you to find out the side effects and help to minimize the prescribing cascade. And the drug information center, when you give, the student will also get a query, and he will be getting a good knowledge acquisition, and how to solve the prescriptions, and awareness about all those prescribing cascades he will get, and help to avoid it, by which you will be able to avoid the pill burden and financial burden. To the best possible, use the proverb, one disease, one drug, once a day, wherever possible. So in this way, you'll be able to minimize the polypharmacy. So in this webinar, I have given only few clues about some of the de-prescribing algorithms and the medicines, but it is also available for statins, antihypertensives, as well as NSAIDs and other medications. So wherever possible in your hospital setting, do research on it, by which the research data will be available. The physicians will also come to know about it. Right. So with that knowledge, they will also be alert, and the general public and the other healthcare professionals will also get an awareness. So this is about the various methods that are helpful to minimize the polypharmacy. And these are the references and the de-prescribing sites which helped us to uh, provide, supplement you with this knowledge about polypharmacy. So be part of the change for a better quality of life. So whenever the person is taking medicines, question whether it is necessary, these many are necessary or not. And based on that, do it. Yes. So in this way, you can be a part of the change for a global healthcare and better quality of life in case of geriatrics. Thank you.
Thank you so much, ma'am. It was a very wonderful session, very informative session. And it was discussed the current scenario of geriatric patients who are encountered with many of polypharmacy regarding. Yes, ma'am. It
Correct.
was a very really an interesting session. We have discussed from basic concepts of polypharmacy to the what are the things we need to avoid, what are the drugs, majorly pantoprazole and these PPS. They are most of the patients that are daily
Absolutely.
using. Absolutely. When we are going for wardrooms also, most of the patients are unnecessarily using the multivitamins which they can be able to get from the diet. So in this way, if you try means it will be beneficial for them both economically and health. Right. Yes, ma'am. Well, thank you so much for the wonderful session and amazing session. We have some questions, ma'am. I will try to project it. Try to answer, ma'am. Thank you so much.
Yes.
It's a question from Uday Banu. How geriatric patients judge himself about proper medication when multiple drugs medicines are suggested by the physician or doctor? How can they judge
Yeah,
him? That
it is a good question because the patients, they believe totally the physicians, and whatever is suggested by my physicians, I will take like. But in this case, what can be done is, what is possible is, you just ask the physician what for this particular drug is provided. If 4 drugs are given in a prescription, question
yes,
them. This drug, it may be NSAID. Ask him what it is for. If it is for leg pain, then you think whether you are able to bear it as a mild pain or not. Whenever it is necessary, you can consume it. Right. And if it is in case of supplementations, vitamin, all those supplementations, if it is possible to manage with the dietary these things, you can manage. And few of the drugs we have seen in our hospitals, even for benzodiazepines, which was abused by 10 years. And during our projects, when we suggested the patient, it is not necessary. If it is
yes,
for 4 weeks, if you have taken, that is enough. After that, you have recovered, you are normal. The patient is not willing to stop the drug.
yes,
Even
yes,
after the physician says, even after the pharmacist counseling, few people accepted the counseling. Out of 120 patients we recruited for our study and performed, few patients did not agree to minimize the dose because of the symptoms, whatever they had, it's strongly registered in their mind. So they don't want
yes,
to go for a tapering only. They will say, and some patients, what they did was, here they accepted as patient counseling, they refilled the prescriptions later. So
yes,
like that it happens. So what is how the pediatric patients, they believe the physicians, it's good, but question them what for this drug is prescribed. And
exactly.
brown bag method will help. Go and show them the medicines. Because when you go for hypertension, cardiovascular diseases, so many cardiovascular are there, isn't it? Angina pectoris, hypertension, myocardial infarction, all these things. And when you look at the pharmacotherapy, almost the same, isn't it? ACE
Yes,
inhibitors, calcium channel blockers, all these things. If the students study these things, that is enough, like it will be, isn't it? So what it indicates, for each of the diseases, if you consult a different physicians, other physician will not be aware of it. So, though it is your physician, have that confidence, take the yellow bag and show him these are the list of drugs prescribed and I am consuming based on the other specialist consultations. That will help you to minimize the drug burden and polypharmacy. It's a very good
thank you
question.
so much.
So
Thank
follow
you.
this.
Yes, thank you, ma'am.
And they can also
For,
use the drug information centers, which will help to
yes,
minimize it.
Yes, ma'am. One more question, ma'am. Can we suggest non-pharmacological therapy for certain conditions to prevent the adverse effects of polypharmacy?
Definitely, definitely. And it should not be. So only the general guideline for de-prescribing, what I told is under the medical supervision. Okay. Inform your physician because have you heard nowadays even diabetic reversal is possible. Okay. So diabetic reversal, how it is happening? I know recently a person whose HbA1c level was around 9.6. With the lifestyle modifications, he brought it to the level of 6.4.
That
So
was amazing, ma'am. Yes.
yeah, he has done a lot of workout with millet consumption as well as exercise, and he himself made his mind. I will not take much
Okay.
stress. So emotionally also he was well balanced, by which he stopped to take avoiding stress as well as regular medications, exercise, lifestyle modifications, food therapy, by which it came back to normal. And there are some research articles which is also speaking about diabetic reversal, and if it is in case of early stages of pre-hypertension, pre-diabetics, instead of becoming as chronic anti-diabetic people and hypertensive individuals, you can go for lifestyle modifications, which will definitely help to minimize the adverse effects. But do it under the medical supervision and monitor the patients. If the symptoms
Oh,
relax, should go for a consultation.
yes, ma'am. Thank you, ma'am. One more question, ma'am. This is then Satish Kumar. Is there any psychological effect in patients in producing sleep if they are discontinuing sleeping pills with a lower dose? Like
Uh,
after cessation? Yes.
Yeah, emotionally, if the patient is depending on that, that's what we should believe the physician as well as the healthcare practitioners are going to do some good to me. Okay, and for all those things, as I suggested in case of antipsychotics and benzodiazepine de-prescribing, how they'll be able to come out. Some relaxation methods will be there. Okay, because most of the time benzodiazepines are administered for minor ailments and secondary insomnia. It might be some grief or something might have happened by which the drugs are prescribed, and later, and nowadays more common, isn't it? Youngsters also have drug abuse, all these things. So to come out of all these things, they will have a sedation whenever there is a tattered child, isn't it? So when the kids are brought up, kids are brought up is in that way, automatically there are more chances of um, they're unable to take up any issues or problems. They're unable to face the issues, isn't it? So in those cases, commonly they suffer with insomnia conditions. So for these conditions, with the medical consultation, slowly, because withdrawal effects may be there, so
Yes, ma'am.
slowly you taper the drug. If it is in case of low doses also, what you can do, the frequency can be minimized instead of taking it every day. If it is BID, maybe OD, or OD instead of every alternate days, or once in 3 days, then once in a week, and slowly you can taper the drug. Yeah, you can try that method.
Yes, ma'am. Thank you, ma'am. And one more question, ma'am. What is the role does clinical pharmacist play in preventing polypharmacy in older patients? That means geriatric patients. How can we explore?
Yeah, one thing what you can do is that start doing research, because when we started working, it was some 2 years before we started working on this concept of de-prescribing. So from the time onwards, we have only published one full text article, that is the benzodiazepine successfully, and the physicians are also coordinated to minimize the doses. Okay. So in that way you can work. So it will provide scientific evidence and outcome to the society. And people start getting an awareness. These drugs can be stopped at one particular point. There is a proof. And many people have done this. So only I have given you all those de-prescribing websites. Go through that, work on this, do research studies. And clinical pharmacists appointed in few hospitals, isn't it? They can take the message to the particular physicians and help in the reduction. Okay, and basically we are all community helpers. All the pharmacists, healthcare professionals are community helpers. After studying pharmacy, from pharmacy practice, all these diseases, patient counseling, what should come to your mind? Even if I am not a good, not in a particular organization or institution, they're supposed to help the society because you have knowledge. You have knowledge, and it is injustice if you're not helping someone. Yes, without that.
Yes.
So you're supposed to take care of your family, relatives, everyone. So now also you might have experienced this, and if a family person is there, the nearby neighbors used to come or they used to
That
send to
was going on, ma'am. Actually, yes.
right. And drug information center is there. Work effectively there. Show your efficiency by which doctors will also gain confidence. It's not that practical now, but try to the possible extent from your side as a clinical pharmacist. Since you have knowledge, the softwares, and the efficiency, prove it to them by which slowly the situation will change.
Yes, ma'am. Yes, ma'am. One last question, ma'am. From Fahad. Is it safe for geriatric patients to simultaneously use Ayurvedic and Siddha products along with the treatment for hypertension? As a
Yeah,
treatment for hypertension?
yeah. That's what I was saying in the previous slides. Do you remember?
Yes,
OTC
ma'am.
medications, complementary and alternative medications, whatever you are taking, many people they think it is many people they consider it as drug. They will consider it as some supplementations like it's not a drug like for them, isn't it? So what should be done? They are supposed to take care of this particular concept. Means Ayurvedic medicines or Ayurvedic herbal supplements or OTC medicines are medicines. Okay. Whether it is aloe vera, whether it is some amla juice, or else any herbal tulasi supplementations, or jamun seed powders, or neem this thing supplementations. All these things are medicines. So all these extracts, when the person is consuming, they're supposed to take care. Okay. And don't reveal it. That's what. Brown bag method. Put it in a bag. Put all the
Yes.
prescriptions, drugs, boxes, containers, and give it to the physician. Show. But this much is prescribed by the Ayurvedic physician. These are the drugs by Siddha products. Can I take it together? Because drug herb interactions is there. Herb interaction is there. All those
Yes.
things physicians will be aware of. And when you question, at least to you, if he is not aware, he will check it, and the next patient at least will be benefited, right?
Yes.
So
Ma'am. Yes.
in those cases, the patients will be benefited a lot. Kindly do it, carry it, follow. Of this webinar, even if you forget everything of this webinar, remember only one thing: brown bag method. Whenever your family members
Yes.
go to the patient, put all the medicines and prescriptions and take them. So the caretakers also can write it and take. That alone you follow. I'll be happy for presenting this webinar.
Actually, it was in a very, we can say, you made like an fully basic things. What are the brown bag from the brown bag? What are the various cascades we have discussed? It was very really informative as well as a motivative session for us, ma'am. Actually, say.
Thank you.
Thank you so much, ma'am. I am very glad to have you today as an expert person. Now I am. Thank you so much for answering all the questions from the delegates,
It's
and
my
we
pleasure.
have get a very good response from the delegates, and still many more questions was there that was they can find out. And now I am handling the session to the Lavanya ma'am. Thank you so much. Thank you.
Thank you. I sincerely thank our principal, Niranjan Babu sir, as well as Lavanya and Sunil for their
Thank,
coordination, support, and for inviting me. Thank you all.
thank you so much.
Thank you so much, madam. It was an excellent session. You can see the comments in the chat box. Everyone are writing informative session, excellent session. Informative session was more rather than excellent. So
Thank
really,
you.
it was very informative, madam. The topic you have chosen is very close to each and every person because one has to experience the polypharmacy in their lifetime. So without the proper updation of polypharmacy and their effects, how to minimize that everything, we can't live a happy life. I think so. This is my personal perception, and still so many questions are posting. I'll pass that questions to your personal mail so that
Sure,
if
sure,
you
sure.
answer, I'll contact them. And one more question from the chat box. I have seen that OTC medicine may fatal sometimes. Yes, it is absolutely correct. And thank you so much, ma'am, for spending your valuable time with us and sharing an excellent information so that we are also updated our knowledge. And when I come to you with the proposal, within no second you have accepted our request. So this shows how you are means how you are sincere towards your education, career, and society related work, everything. And when I'm listening your talk, I just remembering myself that I was in the class. You just, you just bring back us to the class, I feel. So many of your students feel the same thing. And thank you, one and all, for all the participants. Actually, we have released the brochure on Wednesday night, and within 3 days, we have taken 1100 participants from 382 colleges of all over the country, colleges, universities, everything. And I can say Agra, Pune, Dehradun, Tamil Nadu, so many, West Indies also I got registrations. So I thank each and every participant in the name wise. Sunil, may I request Sunil? Sunil, can you connect to Mallikarjuna, sir?
Yeah, ma'am, sure. We can continue.
Hello, good
So
afternoon to one and
now I
all.
request Mr. G. Mallikarjuna, sir, for vote of thanks. Over to you, sir.
Good afternoon. Good afternoon. Good afternoon to one and all. Okay, myself, Mr. G. Mallikarjuna, Faculty, Department of Pharmacology. And on behalf of Seven Hills College of Pharmacy, so it's my privilege to propose vote of thanks. And it's a great pleasure for us hosting this webinar on methods of diminution of polypharmacy among geriatric patients. And at the outset, so I thank our resource person, so Dr. E. Maheswari Garu, Professor and HOD, so Department of Pharmacy Practice, Faculty of Pharmacy, so MS Ramaiah Institute of Applied Sciences, Bangalore. So for her honorable presence and took out valuable time of your busy schedule, ma'am. So that was really so a great and wonderful session. So even so a lot of suggestions and advices can be extracted from the session. So to follow during this pandemic situation. So that was really wonderful situation. So as all the participants are saying, that was an informative session. So really, so a lot of suggestions, advices can be easily extracted. So to follow during this pandemic situation. Okay. So I would like to express my gratitude, sincere gratitude to our beloved principal sir, so Dr. M. Niranjan Babu Garu, and correspondent, so Srimati M. Sumlata Madam Garu, so for their inspiration and for their enthusiastic support for us, so for making such an outstanding activities. And so I heartily thank the convener of this webinar, so Dr. Y. Lavanya, so for convening such an exemplary session. So really, so heartful thank you, ma'am. And so I extend my sincere and appreciation to all my dear colleagues, so for their support and coordination, so for making this webinar in a successful manner. And finally, I thank each and every participant and delegate for being with us for this webinar. So, and it's a great pleasure to be having all these many participants for such a wonderful session. And really, so thank you each and everyone. So stay safe, so stay healthy, and have a pleasant day. Thank you so much.
Thank you, Mallikarjuna, sir.
Thank you, ma'am.
So participants, one more announcement. Feedback link is posted in the description box. You can see the description box for feedback link, and it will be active from the next moment onwards. So you can send the feedback link and you will get the certificate. If you the limit for certificate distribution is 100 per day. So if you are not getting, you can try for another second day. And if you found any difficulty in getting the certificate, you can contact me. So I have shared my email ID in the in your emails. Okay. So thank you, madam. Thank you so much for your presence here. Thank you for all the participants. And thank you, Sunil, for your extended technical support in this. And I thank Dr. Jyoti, madam, for her moral support. And she is the person who behind the webinar. And thank you so much, madam. And so many my senior faculties are there. And I take this platform as thing to thank our senior most faculties and my dear colleagues. And thank you so much, ma'am. Jai Hind.
Thank you. Jai Hind.
जनगण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्चल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मांगे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत भाग्य विधाता जय हे जय हे जय हे जय 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 हे
Jai Hind.
Jai Hind.